GERD is one of the most common diseases in the world, but did you know that it's also very strongly linked with the development of esophageal adenocarcinoma? My name is Maruf, and in this video, I'll go over all the most important features of GERD that you need to know so that you can succeed in taking your boards. Let's get right into it. At its core, GERD manifests as a reflux of stomach contents, like food and acid, into the esophagus. Now, normally, we have a lower esophageal sphincter that will prevent the regurgitation of foods up into the esophagus. We also have crux muscles of our diaphragm that work as an additional external support by putting a little chokehold on that lower esophageal sphincter. So long as the pressures within the abdomen are lower than the pressures within the esophagus, then you should never really see food reflux in the upward direction. However, when the pressures of the abdomen start to exceed the pressures of the esophagus, then that's when you start to develop GERD, as well as all the symptoms that go along with it. Now, there are a lot of different factors that can affect this pressure differential between the esophagus and the abdomen, but obesity and pregnancy are definitely some of the most important risk factors since that increased size of the abdomen will eventually cause the pressures in the abdomen to exceed the pressures of the esophagus. Aging is also a fairly significant risk factor since we see that the length of our esophageal sphincter actually naturally shortens as we age, meaning that there's less and less support there with time. Tobacco products and the use of NSAIDs can also cause an increased risk of GERD since both of them cause inflammation and weakening at that lower esophageal sphincter with time. Lastly, socioeconomic disadvantages can also increase the risk of developing GERD since things like obesity and tobacco is generally higher in these populations. Now, interestingly, H. pylori actually isn't commonly associated with GERD. H. pylori is pretty well known as a jerk of the GI tract, and it actually decreases the risk of GERD, and that's because it causes atrophy of those parietal cells that would normally secrete acid in the stomach, and therefore causing problems like atrophic gastritis instead. Now, H. pylori and the diseases that it goes with are fairly large topics, so we'll have to hold off and talk about those guys in a different video. Now, patients with GERD will classically present with heartburn, also known as pyrosis, but they might also have things like acid regurgitation or a chronic cough. The cough is a bit of an atypical symptom and is usually from acid refluxing into the tracheal tissue. Now, while most patients with GERD are going to have fairly benign courses to their disease, we do need to be on the lookout for patients who might present with alarm symptoms, which would instead suggest the development of cancer. A cancerous lesion will typically induce neovascularization around itself, which means that it increases the amount of blood supply to itself so that it can siphon a lot of the body's nutrients. Now, this will usually cause symptoms like weight loss from that cancerous mass sucking up all of the body's appropriate nutrients. You might also see things like anemia from that slow chronic blood loss, since that combination of that abnormal tumor growth as well as that abnormal neovascularization will increase your risk of chronically oozing blood. Patients might also develop dysphagia, which again is fairly rare for someone with GERD, but is actually one of the most common symptoms in patients with esophageal cancer because that tumor will start to grow and block off the lumen of the esophagus. We're often dealing with patients who have had GERD that is left untreated for long periods of time. We're talking like years. In these folks, GERD can sometimes lead to specific complications, the most common of which is going to be erosive esophagitis, where you have damage to the superficial mucosa of the esophagus from frequent acid exposure. Another important complication of untreated GERD is hiatal hernia. That's where the patient's stomach starts to ascend through the diaphragm and into the actual chest cavity. This usually occurs due to the increased abdominal pressures that end up pushing the stomach through the diaphragm, or due to aging that causes shortening of that lower esophageal sphincter, making it easier for that stomach to slide through. Notice that these are the same risk factors for GERD. It is for this reason that GERD and hiatal hernias are often seen together, where GERD will allow for the formation of a hiatal hernia, and then the displacement of that lower esophageal sphincter by the hiatal hernia will in turn make the GERD even worse. You get a very nasty cyclical course of disease. Now, there are various types of hiatal hernias, but the most common one that you're going to see is a sliding hernia, where the patient's lower esophageal sphincter slides right up into the chest cavity. Another potential complication of GERD is Barrett's esophagus, occurring in about 10% of people with chronic GERD. In Barrett's esophagus, we see metaplastic changes within the esophageal cells as a way to help defend against the frequent acid exposure from GERD. Normally, the lower esophagus is going to be lined with squamous epithelial cells. However, as the area continues to undergo continuous inflammation from frequent acid exposure, the cells of that area will eventually transform into columnar cells, which are more better suited to defend against that chronic acid exposure. Now, that might sound great and all, but in reality, the esophagus found a way to protect itself through metaplastic changes. This does increase the risk of progressing to esophageal adenocarcinoma down the line, and that's the last important complication that you need to be aware of when it comes to GERD. We won't talk too much about esophageal cancer since it's such a rich topic on its own, so be sure to check out a future video on it when we're done watching this one. The diagnosis of GERD is typically going to be clinical, meaning that if the patient has the classic symptoms of GERD, like pyrosis, regurgitation, then that's enough to presume that that's what the diagnosis is, and the next step is just go straight to treatment, which we'll talk about in just a second. Now, if the patient is experiencing GERD symptoms for several years, then that's a little bit concerning because we start to worry, did they already develop Barrett's esophagus, or worse, maybe directly cancer? In these patients, if they have 3 additional risk factors for esophageal cancer, like tobacco use, obesity, or if they're over the age of 50, then you should perform an endoscopy with biopsy next. Barrett's screening is becoming an increasingly common thing that's showing up on the boards, so just make sure you always look at the patient's risk factors before you decide what you're going to be doing next in a patient that sounds like they have GERD symptoms. If it sounds like a benign case of GERD, no problem, proceed right to treatment. However, if the patient sounds like they have a lot of risk factors for cancer, like that obesity, GERD for many years, etc., then you should go straight to endoscopy with biopsy. You should be doing the exact same thing, going to endoscopy with biopsy, if the patient has alarm symptoms as well, like dysphagia or weight loss, again, for that same concern that we have that maybe there's already a cancerous process that's evolving. So remember that if you have a patient with classic GERD symptoms and they don't have any alarm symptoms that are concerning for cancer, then the next step is to start the patient on appropriate treatment, and in this case, it'll be PPI therapy for about 8 weeks. Now, this can be medications like omeprazole, pantoprazole. Really, it doesn't matter because they're all equally efficacious, so just take your pick. You should also make sure to educate the patients about things like weight loss and smoking cessation because the GERD will never really be resolved if the underlying problems aren't resolved as well. Now, we do find that most patients end up failing conservative management with diet therapy and end up requiring the use of a PPI at the end of the day as the medication of choice for their treatment. A PPI works by inhibiting hydrogen potassium ATPase in the gastric parietal cells. Parietal cells, remember, are the cells that normally actually secrete acid, but it's important that these patients take the medications about 30 to 60 minutes before their first meal of the day so that the PPI can actually inhibit these cells appropriately. Now, when I'm in the ER, I'm usually trying to provide my patient with rapid relief, so I often use things like H2 antagonists, like famotidine, to treat my patients because it works much faster than a PPI does. However, studies show that over the course of weeks, a PPI offers a much greater reduction in acid production than an H2 antagonist can offer. So for that reason, PPIs are still going to be the preferred medication in all patients. You can use H2 antagonists as add-on therapy or as rapid relief therapy, but that does not replace the use of a PPI. Now, after several weeks of PPI therapy, if the patient has resolution of their symptoms, then you've technically both made the diagnosis of GERD as well as treated it. And in that case, the next step would be to try and wean the patient off that PPI. However, if the patient continues to have symptoms despite PPI therapy, then your next step is going to be to look for other possible causes for the patient's symptoms. And that's going to be through performing an endoscopy with biopsy. Now, you should know that technically we're not looking for any specific findings on endoscopy, since technically there are no findings of GERD on endoscopy. Instead, we're using the endoscopy to look for other more concerning causes for GERD, because the last thing you want to do is go chasing around thinking it's GERD when in reality the patient has esophageal cancer. It's important that you do these biopsies early to exclude this potentially dangerous diagnosis. If the endoscopy looks normal, as it should in patients with GERD, then you still have to try and confirm the diagnosis of GERD. In that case, the next step will be to perform an ambulatory pH monitoring, which is your gold standard for the diagnosis of GERD. If the ambulatory pH monitoring senses very high levels of acid proximal to that lower esophageal sphincter, then boom, you've confirmed your diagnosis of GERD, and you can consider surgical interventions as a possible next step for this patient. For example, something like a Nissen fundoplication. In a Nissen fundoplication, you're going to take the fundus portion of the stomach and wrap it around the lower esophagus, thereby increasing the strength of that lower esophageal sphincter. Now, in reality, qualifying for this surgery is actually fairly complex, and most patients with GERD do not require this surgery, but the boards still like to test this procedure, so it's definitely a good one to know. Alrighty, why don't we fortify what we've learned about GERD today by doing some practice questions, starting with this one. Now here we have a pretty straightforward question that's asking us about the complications that are associated with GERD. Now remember that GERD, when left untreated, can lead to metaplasia of the esophageal cells, causing Barrett's esophagus. Since these cells have a higher risk of progressing to cancer, GERD is technically also associated with the potential risk of esophageal adenocarcinoma. Now, a lot of patients with GERD will also develop erosive esophagitis from that acid constantly hitting up against the esophagus. Lastly, remember that GERD also is associated with hiatal hernias, where most commonly that lower esophageal sphincter will get displaced and shoved into the chest cavity, and so having GERD technically increases the risk of developing hiatal hernias and vice versa. Thus, by process of elimination, H. pylori, or D, is your best answer. Now, some of you might have remembered that I mentioned H. pylori really quickly before and how it is usually not seen in GERD. If anything, it can decrease GERD symptoms because H. pylori will lead to atrophy of the gastric parietal cells, therefore actually reducing the amount of acid that's produced. But even if you didn't remember that fact, you can still get the answer right just by process of elimination here. All right, why don't we try another one? Now, in this case, we have a patient who has GERD symptoms despite being on a PPI. If we go down our failed treatment algorithm, then we know that the next step is to perform endoscopy with biopsy to look for other potential causes for the patient's symptoms. Now, here the patient has already undergone the endoscopy and showed very normal tissue. We know that these patients now require a confirmatory diagnostic testing, and that's going to be in the form of esophageal pH testing, which is the gold standard for the diagnosis of GERD, and in this case, C will be your correct answer. Now, esophageal manometry and barium swallow typically don't have a role in the evaluation of GERD, and you're usually only getting them if you see symptoms of dysphagia, which this patient doesn't have. And we talk more about dysphagia in future videos. Now, since this patient is already on max therapy for PPI and has failed and has had rule out of other possible diseases like cancer, they are a potential candidate for reflux surgery disease. But a patient must always have a confirmed diagnosis of GERD with pH monitoring first before they can be eligible for the surgery. If this video helped to make sense of the jumble of facts that surround GERD, then be sure to check out my upcoming videos in this series, where I talk about other disorders that can present very similarly to GERD and how you can differentiate between them. Until then, check out some of the other videos that I have on my channel, and I'll see you there.